Discuss a very important seronegative spondyloarthropathy and ankylosing spondylitis. It is seronegative because it does not contain any ANA, any RF, any anti-CCP. So these antibodies are not present in case of these seronegative arthropathies. So it is a chronic progressive inflammatory arthritis that primarily affects your axial skeleton, for example spine, sacroiliac joints, chest, and it leads to fusion of the spine. When spine is fused, then it leads to reduced mobility. Etiology and risk factors. It has a strong association with HLA-B27. So it is almost 90% of the cases have HLA-B27 positive, and it is mostly seen in the young males. Age is 15 to 35 years. Mostly seen in young males age 15 to 35 years. Family history of spondyloarthritis may be positive, and clinical presentation. You may have musculoskeletal features and you have extra-articular features too. Musculoskeletal features, as it involves your axis mainly. So there is low back pain and stiffness. Low back pain and stiffness, and it slowly develops and progresses. Pain improves with activity. It is an inflammatory condition, so pain improves with activity and it worsens with rest. So there is early morning stiffness that lasts more than 30 minutes, and it improves also with activity. There is reduced spinal mobility because of spine stiffness, and on x-rays you will see sacroiliitis. Sacroiliitis is bilateral. You should remember this: bilateral and symmetric sacroiliitis. It differentiates it from other axial spondyloarthropathies. Enthesitis. Enthesitis is inflammation of the tendon and ligament where it joins the bone. So enthesitis is inflammation at tendon and ligament. Mostly we see Achilles tendinitis and plantar fasciitis. Plantar fasciitis. Dactylitis is also very common in case of ankylosing spondylitis. Dactylitis leads to sausage digits. There is kyphosis seen in advanced stages. It is on x-rays it looks like a bamboo spine when the kyphosis develops in spine. As I told you, extra-articular manifestations are also very common in ankylosing spondylitis. Uveitis and iritis is almost seen in every spondyloarthropathy like psoriatic arthritis, etc. But ankylosing spondylitis typically has aortitis, which leads to aortic regurgitation, apical pulmonary fibrosis, and it is seen bilaterally just like in TB. So apical pulmonary fibrosis, peripheral arthritis, and the changes in this peripheral arthritis are permanent. It involves large joints like hips, shoulders, and knees. Also, there is fatigue and constitutional symptoms like seen in other inflammatory and autoimmune conditions. And in case of ankylosing spondylitis, there may be cardiac conduction system involvement leading to heart block. Heart block. Leading to heart block. Diagnosis. Investigations. HLA-B27 is positive in almost 90% of the cases of ankylosing spondylitis. ESR is raised because of inflammation, and radiographs are done, X-ray and MRI. X-ray changes appear later, but MRI can detect early changes. Early changes are subchondral erosions and sclerosis. Sclerosis of the ligaments and bones. Late fusion of the sacroiliac joints is seen. The gap between sacrum and ilium is reduced. Bamboo spine is seen. Here you can see bamboo spine. This bamboo spine forms due to syndesmophytes, and these syndesmophytes are found because of ossification of nucleus fibrosus. Nucleus fibrosus. So nucleus fibrosus ossifies, and also lateral and anterior and lateral spinal ligaments also calcify. So due to these calcifications, you will see syndesmophytes that lead to the development of bamboo spine. Management. First one is non-pharmacological. Non-pharmacological management mainly consists of physiotherapy and exercise training. This is the cornerstone of management. Postural training, spinal extension exercises, smoking cessation, these are very important. But we go for pharmacological management too. NSAIDs are given as first line agents because they reduce pain and inflammation, for example, indomethacin, naproxen. Then, if these don't work, then we go for other agents like methotrexate, sulfasalazine. And if these don't work, then we go for TNF alpha inhibitors like infliximab, etanercept, adalimumab. If other agents are also available like interleukin 17 inhibitors including secukinumab, exekizumab, exekizumab, and corticosteroids have a very minimal role in case of this seronegative spondyloarthropathy. We can also use JAK inhibitor. JAK inhibitors like tofacitinib and abatacitinib. Tofacitinib and abatacitinib. Surgical management may be required. For example, there is hip arthroplasty for hip joint involvement if there is severe deformity. And spinal osteotomy can be used in advanced kyphosis. So this is all about ankylosing spondylitis.